Good evening. My name is Shabnam Sood and I'm presenting a case report of stuttering induced by risperidone and chlorpromazine. Stuttering is defined as a disturbance in the normal fluency and time patterning of speech, which is inconsistent with the individual's age and language skill. It includes frequent and marked occurrences of sound and syllable repetitions, sound prolongations, broken word, audible or silent word blocking, words produced with excess of physical tension, monosyllabic whole word repetition, and circumlocutions. Developmental stuttering is more common and generally develops gradually in childhood or adolescence. In contrast, acquired stuttering may start suddenly at any age, and factors implicated include stroke, brain tumor, head trauma, and other conditions causing disruption in brain functioning. One of the factors implicated in the causation of stuttering is overactive presynaptic dopamine systems in the region of the brain that modulate verbalization. It is a rare side effect of antipsychotic medication, and this case report is of a patient who developed stuttering when treated with risperidone and chlorpromazine. Mr. F is a 37 years old African American male who had been released from jail a week prior where he was on Risperdal. He has a previous history of schizoaffective disorder and amphetamine and cannabis use disorder who was sent to a crisis center after he was found lying in the middle of an intersection chanting incoherently and making illogical statements. At the crisis center, he was given intramuscular injections of haloperidol and Ativan and was then transferred to the hospital on an involuntary commitment process because he was largely uncooperative with treatment. On admission to the hospital, he was agitated and labile with paranoid and grandiose delusions. He was noted to have a severe stutter. He denied current use of drugs and alcohol but has an extensive past history of amphetamine and cannabis use. His medical history was significant for hypertension, and blood work revealed mildly elevated liver enzymes but was otherwise unremarkable. He did not provide a sample for urine drug screening. A review of his medical records revealed that he has no past history of having stuttering during childhood or adolescence. He has had 4 previous hospitalizations. He was treated with haloperidol during the first 2 admissions. No stuttering was noted in his records. He was stabilized on haloperidol palmitate as an outpatient prior to his 3rd admission, and he was not reported to have had any stuttering. Patient decompensated secondary to amphetamine use, and due to his increasing agitation and psychotic symptoms, he was taken to the urgent care center where he received chlorpromazine. He was transferred to the hospital for inpatient stay, and stuttering was noted on admission. During this hospitalization, he refused paliperidone. Haloperidol and valproic acid were initiated to decrease psychosis and to stabilize mood. Although his stutter improved, he had a poor response to haloperidol. This antipsychotic was changed to olanzapine with improvement in his psychosis. Some stutter was present at discharge. In a subsequent admission 1 year later, he was treated with olanzapine and valproic acid. No stutter was noted at admission or during his hospital stay. During his current admission, Mr. F was started on risperidone and the dose titrated rapidly to 3 milligrams twice a day. Valproic acid was added to stabilize mood. He had good levels at 1000 milligrams a day. His agitation and psychosis decreased, and 2 loading doses of paliperidone palmitate 234 milligrams on day 8 and 156 milligrams on day 13 were subsequently given. He became more coherent and complained about his stutter. Risperdal was discontinued on 14 days and continued to improve until his discharge to a step-down unit 8 days later. On discharge, which happened on day 25, he had only a minimal stutter. Discussion. Stuttering was first noted to be caused by phenothiazines, trifluperazine and chlorpromazine in one patient and fluphenazine in another patient in 1981. Clozapine appears to be most frequently implicated as a causal agent for stuttering in 16 cases. There are 2 mechanisms postulated for the development of stuttering with clozapine. Either it is a part of seizure activity or could be a variant of movement disorder. Drug-induced stuttering has been reported with other psychotropic medications, including antidepressants, desipramine, sertraline, and fluoxetine, benzodiazepines, including alprazolam and chlordiazepoxide, and mood stabilizers including lithium. Risperidone has been implicated in the cause of stuttering in 3 cases. In a case reported by Lindquist, the patient had a past history of stuttering. It appears that the risperidone reactivated the old speech pattern at doses of 4 mg. The patient's dose was increased to 8 mg to target psychosis, and the stuttering worsened. He was continued on risperidone 8 mg, and on day 48 both the psychosis and stuttering improved. In another case, stuttering was noted to be dose dependent, with the patient developing stuttering at a dose of 4 mg and higher. While the first 2 cases were patients who developed acute stuttering within few days of starting risperidone, the third case reported that risperidone was used chronically. The patient had moderate mental retardation and was on low dose of risperidone 1 mg a day for treatment of behavioral disorder related to perinatal asphyxia for 2 years and then developed stuttering. Our patient, Mr. F, experienced stuttering several times that improved and resolved once a risperidone was decreased, suggesting risperidone-induced stuttering. He also had stuttering after he received intramuscular injections of chlorpromazine. This is the first case report of a patient who developed stuttering in the context of both low and high potency neuroleptic medications. Various mechanisms involving multiple neurotransmitters have been postulated about the connection between neuroleptics and stuttering. Cholinergic mechanisms have been postulated since tricyclic antidepressants are seen to worsen or cause stuttering, and trials with bethanechol, a cholinergic agent, have improved fluency. It is speculated that drug-induced stuttering may be a manifestation of akathisia, leading to noradrenergic and serotonergic mechanisms being implicated. 1/3 of cases involve selective serotonin reuptake inhibitors. Neuroleptic-induced stuttering suggests that dopaminergic mechanisms may be another cause. However, this could be due to the intrinsic antimuscarinic activity of low-potency drugs. In contrast, risperidone is a high-potency drug that blocks the D2 and 5-HT2 receptors with no actions on the muscarinic receptors. It could be that either the dopamine or serotonergic system are involved, or there is an imbalance of these systems after starting risperidone that may be relevant. Risperidone-induced stuttering is an interesting paradox, as risperidone is also used in the treatment of stuttering. Risperidone improves stuttering symptoms by increasing striatal metabolism by way of D2 receptor antagonism. However, the use of risperidone in the treatment of stuttering and the fact that stuttering occurs as a side effect of risperidone is an interesting paradox, and further studies are needed to clarify the mechanisms. Thank you.